Hello, everybody. Welcome to World Pneumonia Day activities, Keeping Child Health on the Global Agenda. My name is Josh Sharfstein. I'm the Associate Dean for Public Health Practice and Training. I really thank everybody who put this event together and really looking forward to hearing discussion of particularly pneumonia and diarrhea and the incredible burden that they place on child mortality around the world. We're going to have a series of really interesting presentations and then an interesting discussion that I will moderate with questions from you all, so start thinking about them. The first speaker who will be presenting the report itself is Dr. Madhu Santosham, who I'm sure everybody knows here. He is a hero and international expert in oral rehydration, childhood vaccines, and the dissemination of all kinds of pediatric interventions around the world. He serves on many different committees, consults with every international agency and major foundation working globally, and has written more than 250 papers. He will be talking about the 2016 Pneumonia and Diarrhea Progress Report, Reaching Goals Through Action and Innovation.
Thank you, Josh, for that very gracious introduction. I've been in public health now for about 35 years, and it's just remarkable what's happened in the last 35 years. And, how do I forward this? Okay, there we go. So you can see when I started my career, was back, does this work? Anyway, if you look on the way to the left, 20 million deaths each year. We're now down to 6 million. It's still a long way to go, but we've remarkable 70% reduction, 90% reduction in diarrhea deaths. When we used to give lectures those days, we used to say a child dies of diarrhea every 6 seconds, every 5 seconds, and a child dies of respiratory disease every 4 seconds. That's what we used to see. But you can see we made a lot of progress, but we still have a long way to go. We still have over 500,000 deaths from diarrhea and over 700,000 deaths from pneumonia. And the sad part of it is a lot of this is either preventable and either preventable or treatable. And one of the most remarkable discoveries of our century, as it was published in the Lancet, is the most remarkable, one of the most important discoveries of the century was oral rehydration therapy. And those of you who are new to the school, Johns Hopkins University and this school, particularly this school, played a major role in the important discovery of ORS and its dissemination around the world. And this is what's happened. We had 5 million deaths before, and you can see it's now down to a little over 500,000. And over 60 million lives have been saved because of this one intervention over the last 35 years. But the sad part of it is the coverage is still only about 30 to 45%. In spite of the fact that this is a powerful intervention, it costs pennies, almost nothing, and it can be easily be distributed at the home level. We can talk about during the discussion session as to why this is not happening and what the opportunities are to actually get this out. Zinc supplementation, lots of studies have been done, particularly by Dr. Bob Black and this, the former chair of international health, Abdullah Baki, and several others from this institution who have done work on zinc supplementation, and they've shown that it has the potential to dramatically reduce the severity of diarrhea. And in one study, it actually showed a reduction of 46% in all-cause mortality when it was used for 2 weeks after a diarrheal episode. In spite of that, the coverage here is abysmal. Even the countries that are using zinc supplementation, the coverage is less than 5%. So, in summary, then, we have about 1.5 million deaths that still occur. You might wonder why the last slide said 1.3 million and this one says 1.5 million. The last slide was the deaths between 1 and 59 months of age, and this one is all children under 5 years of age. The number of deaths that occur are more than the combined HIV, TB, Zika, Ebola, and malaria. Tremendous amount of resources go into those diseases, and I'm not grudging that at all. I think that's most appropriate to do that. But we need to also pay attention to pneumonia and diarrhea, which cause more deaths than these. And it's also important to realize anyone of any age is at risk for these diseases. But the highest mortality is of the youngest children and the elderly. Unfortunately, I've joined the elderly group now, and I have a vested interest in promoting this. Now, we do know how to protect, prevent, and treat, and I hope by now all the students are familiar with the Integrated Global Action Plan, the so-called GAP-D. This is a major initiative by WHO that's been initiated a few years ago. And I'm not going to read through those. We know ways of protecting. One of the most powerful things we can do is promote breastfeeding. But the breastfeeding coverage is actually abysmal around the country, exclusive breastfeeding. We have a number of preventive strategies, including powerful vaccines, hand washing, safe drinking water, and treatment. And we all know that treatment for both pneumonia and diarrhea is very effective if you can institute it quickly. I don't have time to go through the coverage for these things, but again, the coverage is not nearly where it should be. The other important thing to realize, we have strategies for preventing both and treating both pneumonia and diarrhea, but there are so many common strategies between these two diseases. If we can only integrate our strategies for interventions between the diarrhea and pneumonia and vaccine programs, we would be far more effective. We have all these vertical programs that don't necessarily talk to each other, and we lose opportunities to both prevent and treat diarrhea and pneumonia. So what does this report actually say? 72% of the global burden occurs in just 15 countries. So if we could concentrate on those 15 countries, we could tackle 72% of the global burden. The GAP-D scores, for those of you not familiar with this, this was actually developed by IVAC. It takes into account about 10 of the major interventions and looks at the coverage for those interventions and then comes up with a score as to how the country is doing. And you can see the score ranges from 20% Somalia and 74% in Tanzania. But none of the 15 countries who have the highest mortality meet the 86% target. The good news is 12 countries actually improved their GAP-D scores in 2015. And only 6 of the highest burden countries have introduced rotavirus vaccine in their routine program. And we know that's a very effective vaccine. The same with the pneumococcal vaccine. 5 of the highest pneumonia burden countries don't use PCV. And this is the GAP-D score. You can I'm not going to spend much time on this because it's very clear that there's a very wide range of how the countries are doing with their GAP-D interventions. So clearly there's a lot of room to improve the implementation of these interventions. This is the rotavirus vaccine coverage across the world. You can see Africa is actually doing pretty well. The problem we have is Asia. Asia has been very slow in accepting rotavirus vaccine, and it's exactly the same thing with PCV. Fortunately now, Bangladesh and Pakistan are actually started using PCV, and we're hoping very soon India will begin to use PCV, at least regionally in some states. So what's for the future? I think we need to look at new vaccines, RSV and influenza for infants, probably administered through pregnancy. Reducing indoor air pollution. We have done a very poor job of controlling indoor air pollution. Diagnosis of pneumonia is a huge issue. We've been working on this now for 30 to 40 years. We have not really gained much ground because we still do not know on an individual child whether that child has a bacterial infection or a viral infection or even a non-infectious disease that's causing the rapid breathing. Bill Chuckley is here. He has pioneered the use of ultrasound for chest ultrasound, which we think ultimately could replace chest X-ray and make it accessible very much at the remote levels. pulse oximetry and oxygen therapy. I think Eric will be talking about that later on. There are also new techniques, new biomarkers to distinguish bacterial and non-bacterial causes that are right now in the experimental stage. We're hoping that very soon they will become, that we can use them in the field. Lately, people have been using CPAP for hospital care. This is something that actually started in the US and other places. When I started my residency here in Baltimore back in 1971, it's now being field tested in many sites in developing countries. So in conclusion then, globally we've made enormous strides have been made to reduce pneumonia and diarrheal morbidity and mortality, but over 1.5 million children continue to die. We have many powerful strategies, but the key is we must have a comprehensive approach in order to obtain optimal results. But as you all know, in order to get these things done, we need political will, we need accountability, we need community engagement, we need community leaders to participate in this, and we need to mobilize and implement these powerful strategies. Thank you very much. I'll stop here now.
Fantastic. Thank you so much. I will say that I've been to some presentations lately, none of which were 10% as succinct and impactful as that one, and how you framed the problem and talked about some solutions. So thank you for doing that. That's a lot harder than it looks to do. I'll just say that. We're going to have two comments from discussants before we open it up for questions, one of whom is Dr. William Checkley, Associate Professor of Medicine, International Health, and Biostatistics in the Division of Pulmonary and Critical Care at the Medical School. Dr. Checkley's research has focused on the conduct of longitudinal cohort and population-based studies in low and middle income countries.
Well, I wanted to thank the organizers of this meeting for inviting me to speak with you today. And I wanted to address the point of lung ultrasound, but I wanted to follow up what Dr. Santosham said. I'm also an alumnus of the Department of International Health, and I recall looking at the numbers of the burden of pneumonia and diarrheal disease. And since I've graduated from here, I've seen great strides in the introduction of rotavirus vaccine, increased pneumococcal vaccine coverage. And it is quite impressive to see the changes in how how the research has moved to implementation, how it's made differences in people's lives. But I don't want to talk about implementation. I'm going to actually focus on a component of research, and what my group has been very interested in doing is thinking about a point of care approaches for the diagnosis of pneumonia. And in the last several years, we've been very interested in the use of lung ultrasound for that point-of-care diagnosis of pediatric pneumonia. So in this presentation, I just wanted to go through a couple points. Wanted to discuss, do we need better point-of-care diagnostics for pneumonia? Is lung ultrasound a reasonable alternative to chest X-ray? And does it add value to the clinical information that we collect? So we all are familiar with the IMCI algorithm, the Integrated Management of Childhood Illness, that is based on symptoms and signs. And I think this is a critical community-based algorithm that helps to identify kids who are sick and need treatment without the need of a physician. The issue is that the algorithm has moderate sensitivity and lacks specificity, and there's additional information that could be added to be able to improve on this algorithm. And that's where we became interested in the use of lung ultrasound. And recall, not all pneumonia needs clinical imaging or imaging to show that there's a problem in the lungs. I think you can actually do a diagnosis of pneumonia clinically and treat it that way. But just giving some additional information can help really target treatment, especially in settings where there's worry that it could be some other disease, whether there's like You know, are you really dealing with pneumonia, or dealing with malaria, or are you dealing with conditions that don't necessarily require antibiotic treatment? So why ultrasound? You know, nowadays ultrasound devices have become widely available. You can find them pretty much all throughout. We have been in like many research board settings, and you do see ultrasound systems. They become portable and battery operated. I think there are ultrasounds that you can actually hold them in your hand. They're handheld. And you can just have a probe for use, and there's no radiation. That's a big advantage over X-ray, and that means that you can actually repeat its use. And it's fast to perform. You can do it under 10 minutes. That's one of the things we found. And we also think that it's a tool that can be taught, and it can be taught at very different levels. So how does it work? You know, and when you think of lung ultrasound, the way we thought about lung ultrasound, if you have a medium where there's just air, it's not a useful tool, like the lungs. But I think once you have diseased lungs, where there's fluid in the lungs, lungs are touching the pleura, or there's any type of accumulation, that's when you start seeing things. And I think that's where it becomes useful. And you can actually see here as an X-ray where you see a consolidation on, basically just means that it's filled with pus. And this is a view in the ultrasound. In the ultrasound, you usually don't see much. It looks just like a TV. And what happens is that because there's no transmission of ultrasound waves, all you get are artifacts, which are just kind of like reflections of the pleural line down the line. But that pattern changes as soon as the lung starts getting filled. And you can get changes in the appearance of the lung. In this case, what we call kind of a down hypoechoic, or kind of a dark image is what indicates there's something in the lungs that's filling it. We had an opportunity to look at other studies, previous studies that have looked at ultrasound as an imaging alternative for pneumonia diagnosis, and we published 2 meta-analyses, one in adults and one in children. And the one here on the right shows the summaries in children, and it shows that it does have quite high sensitivity and specificity for the diagnosis of pneumonia. But a couple of things that we found is that the limitations of prior research is that they've been done in small samples, in very different populations. And most of the studies have been clinical based. You're thinking about in a neonatal intensive care unit, you're thinking about in hospital-based conditions, and pretty much all of these studies have been done in high-income countries. And there could be problems with selection bias, and also variability in the diagnostic standards. So we had an opportunity to conduct a study in a tertiary health center in Peru, at the Instituto Nacional de Salud del Niño. It's a pretty large hospital in Lima. And we had an opportunity to go to the outpatient centers, to the emergency department, and inpatient wards, and identify children aged 2 to 59 months, in which we looked at a group of children with primary respiratory complaints and also a group of healthy controls. One of the things that we found is after training our physicians, there was pretty high agreement in the use of lung ultrasound. As you can see, it's kind of pretty good to pretty well, pretty good agreement in terms of the use of lung ultrasound. 0.77 is pretty decent. Just as a comparison, on our chest X-rays, we've had kappas that are about 0.4. Just as a comparison. So there's more agreement among readers with the ultrasound than with X-ray. When we compared our findings of ultrasound against X-ray confirmed pneumonia, we very similar to the prior studies, we found pretty high sensitivity and specificity, whether you focus on any abnormality or whether you focus on consolidation, with pretty high areas under the curve. And when we also took the times that it took to do the ultrasound, it was kind of under 10 minutes. So even in children who had disease, or where you're spending more time looking at the lungs and doing measurements, it just didn't take more than 8 minutes. This has always been a concern. Now, it's going to take 20, 30 minutes to do, and I think there's a learning curve. It takes some time to get used to using the device, but once you get to be pretty good at it, you can really get it under 10 minutes. And it's pretty point of care, as you think of it. You don't have to wait develop the image and have a radiologist read it. A lot of this we've had an opportunity to teach physicians, not only in Peru but also in Bangladesh, how to be able to make interpretations in real time. We also think that the use of a lung ultrasound may add value to the current algorithms of the WHO. This is a study that we also did in Peru, and in Peru and in Nepal, where we're able to look at children that came in with respiratory symptoms, some who did not meet the criteria for pneumonia by WHO and some who did. And one of the things that we found was that, very similar to what's seen in the literature, about 1 in 5 of children who meet WHO pneumonia criteria have consolidation. But there's a group of children that still have consolidations even though they don't meet WHO criteria. So combining lung ultrasound with the IMCI algorithm could not only help identify kids who actually have pneumonia based on the algorithm and need treatment, but could also identify the group of kids that are also are being missed by the algorithm. And then does it add value to clinical data for chest X-ray confirmed pneumonia? So we used our cohort in Peru in the group of kids who had respiratory symptoms, of which about 26% had chest X-ray confirmed pneumonia. And we wanted to look at what factors were associated with radiographically confirmed pneumonia in these additive scenarios. What happens if you have reported symptoms and clinical signs only? Then you go ahead and add lung auscultation and oximetry, and then you add lung ultrasound. And one of the things that we found is that when you just used reported symptoms and clinical signs, there was poor discrimination for pneumonia. The AUC was only 0.65, and probably chest and drawing was the most the most value added sign for pneumonia, with an OR about 2. When we went ahead and added signs of findings of crackles in the absence of wheezes, we saw an important increase in the area under the curve for discrimination on pneumonia. But interestingly, when we added oximetry saturation, it just really didn't improve the area under the curve significantly. When we looked at presence of consolidation on lung ultrasound, we also saw further improvements in the diagnostic algorithms. So now the AUC is 0.85, and recall they went from 0.65 to 0.85. So in conclusions, we think that lung ultrasound is a promising tool to be able to improve pneumonia diagnosis in resource-poor settings. It is a point-of-care device. It's easy to be able to carry it even to the household for diagnosis. It appears to have high sensitivity and specificity versus clinical diagnosis or even chest X-ray confirmed pneumonia. And in our studies in Peru and Bangladesh, we've noticed that we can actually perform it quickly without major disruptions to workflow in clinical settings. And there's high agreement among practitioners and pretty well tolerated by children. And the part that we've been working on is that, yes, to be able to show that it can be easily taught. And a big advantage of our chest X-ray as an imaging modality is that it has no radiation. So it allows you to actually do longitudinal follow-up, which I think is also a critical component in following the time course of pneumonia. So thank you. I wanted to thank our funders and also have an opportunity to thank collaborators in this project.
Great, that was a fantastic presentation. Thank you very much. Our next speaker is Dr. Eric McCollum, Assistant Professor of Pediatric Pulmonology in the Udo Wood Division of Pediatric Respiratory Sciences at the Johns Hopkins School of Medicine. And he has a joint appointment in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. This is the size of his business card. It's got a lot. He is an expert in childhood respiratory disease in developing countries, with 10 years of pediatric and research experience in low-resource settings in Southern Africa and South Asia. He is currently based in Bangladesh as the principal investigator of an NIH Career Development Award studying the role of pulse oximetry in child pneumonia care in rural Bangladeshi children. Dr. McCollum will be brought in.
I'm talking about pulse oximetry today as an intervention to reduce child pneumonia mortality. So I have no disclosures. So this slide here is a diagram of a patient's journey through the healthcare system of a low-resource country. And so just to orient you, so where the green arrow is here is the home, here's the patient, here are the caregivers, here's the community health worker. This is a frontline outpatient health center, and here's the hospital. And as a patient with pneumonia moves through the care pathway, objective diagnostics and interventions that keep the child on this care pathway until cure is achieved and are feasible to be introduced as far downstream in this care pathway as possible, ideally to the community level, have the greatest potential to reduce child pneumonia mortality, improving outcomes. And today I'll talk to you about how pulse oximetry fits a profile of such an intervention. Before I do that, I need to get everybody on the same page. So I'll define oxygen, oxyhemoglobin saturation, and hypoxemia. So oxygen is a primary energy source in the body. It bulks to hemoglobin. Oxyhemoglobin saturation is the proportion of hemoglobin within red blood cells that's loaded with oxygen, and hypoxemia means low oxyhemoglobin saturation in the bloodstream. If severe, hypoxemia can be life-threatening, and it's a major fatal complication of pneumonia and other severe illnesses. And here you can see, as a cartoon of the pathophysiology of pneumonia, you can see a healthy section of the lung called the alveoli, where gas exchange occurs. And here, where the green arrow is, this is an example of alveoli that are dealing with pneumonia. So the process of pneumonia causes widespread inflammation, fluid collection within the lung, and specifically in the alveoli, and this can disrupt the diffusion of oxygen through the alveoli into these adjoining capillary blood vessels, which can result in hypoxemia. So about 1 to 2 of every 10 children hospitalized with pneumonia in sub-Saharan Africa, South Asia, and Southeast Asia have hypoxemia. The community prevalence of hypoxemia is less certain. Clinical signs are not accurate in detecting hypoxemia. And that brings in pulse oximeters. Pulse oximeters can estimate without being invasive, and they're more accurate for detecting hypoxemia than clinical signs. A measurement of less than 90% is considered to be hypoxemia per the World Health Organization. And so a pulse oximeter is comprised of several components. So the green arrow here is pointing to the probe, which is typically a clip or a wrap, which goes over a finger, toe, or earlobe. And this probe measures the ratio of red to infrared light that passes through this site of measurement. That ratio is then communicated to this box, which is a microprocessor, and it also has a display, and that ratio is then converted through a regression equation to an oxygen saturation measurement, and it also displays the pulse rate, as well as there's a quality indicator usually that goes with so you can assess whether the measurement is a quality measurement or not. Malawi is one of the first countries to have data on the impact of pulse oximetry at the lower health system levels, at the health center and at the community health worker levels. So in a study that's coming out in the bulletin of the World Health Organization, we had introduced pulse oximetry into 2 districts in central Malawi, which is in southern Africa, as a part of a PCV impact study. And we introduced it across the health system, including at the health center and community health worker level. And basically our 3 kind of major findings were that measuring an oxygen saturation was feasible with lower health system level workers. So more than 94% of 14,000 children with pneumonia in Malawi had a successful pulse oximetry measurement by the health workers that we had trained during this time period. Secondly, an oxyhemoglobin saturation of less than 90% compared to 90% or higher increased correct referrals of eligible children to 84.3% from 41.3%, suggesting that a low oxygen saturation level can keep children, or at least encourages children to stay on that care pathway that I introduced earlier. And lastly, when assuming that outpatient pulse oximetry is not implemented, which is again the norm throughout low resource settings, the current WHO guidelines fail to refer more than 2/3 of patients with an oxyhemoglobin saturation less than 90%. So again, this kind of supports the notion that without pulse oximetry, children who have hypoxemia are likely to fall off of this care pathway. So what are the gaps with pulse oximetry? How come it hasn't been implemented yet more widely at these lower health system levels? Well, more health outcome data is needed in other settings, more than Malawi. Pulse oximetry devices appropriate for children remain too expensive. The price point for quality devices that provide accurate measurements are more than $200 to $250 per unit in US currency. There's also no adequate reusable probes for children that are 0 to 5 years of age that are within a reasonable price range. And what I mean by that are probes that are accurate, they're robust and durable, and that they fit children well. And I wanted to take a moment to just introduce a project that is a multidisciplinary project being led by LifeBox Foundation, which includes industries, A-Care Technology, PhysioMonitor LLC, as well as University College London at the Institute of Global Health, Johns Hopkins, and of course the Malawi Ministry of Health. And this is a project that the goal of this is funded by the Gates Foundation, is to develop a novel pulse oximetry probe for children younger than 5 years of age. And you're probably wondering why I have a picture of feet here. And so through end user feedback, through focus group discussions, as well as through expert opinion, this project is in the process of developing a probe that is specially designed for children's feet, which is an underutilized, the toe specifically, which is an underutilized site for measurement in children. And this probe will also be able to be used on the fingers, so we're excited about that. And so that's in process. So what are the additional gaps? So the threshold of an oxyhemoglobin saturation of less than 90%, we think needs re-examination. Again, our group from Malawi has data that will soon be published that shows that patients with an oxygen saturation between 90 to 92% are independently at risk for mortality. And then also, where in the patient's individual care pathway should an oxygen saturation be taken? And we think that this more data is also needed here. So you can see right now it's recommended that patients have their oxygen saturation measured after they're screened to have cough or difficult breathing. And the assessment for difficult breathing is actually a harder assessment than you might think. And so we think that this results in missed cases. So patients who are not screened properly, they don't get an oxygen saturation performed, and they never fully enter that care pathway that I showed you. So instead, if we were to move the oxygen saturation measurement to at least be in parallel to this screening or even before, then this has the potential to reduce the missed cases. But more data is needed here in terms of feasibility and kind of the magnitude of the potential impact. Pulse oximetry to reduce child mortality it must be linked to treatment. So, and what I mean by that is, of course, oral antibiotics, but also closer home follow-up and oxygen. So I want to take a moment to talk about oxygen. So oxygen has not been adequately implemented at hospitals in low-resource settings. You can see here a picture of an oxygen cylinder in really a bad state in Bangladesh, where I currently live and work. And you can compare that to the ideal scenario in this cartoon of an organized inpatient ward with an oxygen concentrator, which takes ambient air and concentrates it into oxygen using, and it requires electricity. It can split the oxygen using these cables to a well-organized inpatient ward setting. And I take a moment here to highlight that a really important initiative has been started in Ethiopia called the United for Oxygen Initiative. This is Ethiopia as a country has taken on the task, the challenge of introducing pulse oximetry and oxygen throughout the country. So it's very exciting, and there's a very nice Lancet commentary authored by Amy Ginsberg from Save the Children and colleagues, which has been released, I believe today, in Lancet Infectious Disease. So I'd call your attention to that if you're interested in reading more. It's also, I believe this is also discussed in the report that's being released today. Power issues, electricity is still a major barrier for successful oxygen implementation at community hospitals and also ideally at rural outpatient health centers. As I mentioned, oxygen concentrators require electricity, and this is not always available. In very exciting work that's being done both in Papua New Guinea and Nigeria, the teams are exploring the feasibility of implementing solar power, as pictured here, to provide constant electricity for oxygen systems, but also for the overall hospital operations. And then lastly, we need more data on advanced oxygen treatment, such as bubble continuous positive airway pressure, which Professor Santosham mentioned. So there's a lot of excitement over this modality. And we need more data. In Bangladesh, a very exciting randomized controlled trial was conducted and published, I believe, 1 or 2 years ago, which showed that bubble CPAP in children with pneumonia reduced mortality as compared to low-flow oxygen. And that was conducted in a tertiary intensive care setting. And there's several ongoing studies with randomized controlled studies. One is in Rwanda, the other is in Malawi, which is investigating the effectiveness of this modality in different settings and also at the district hospital level where there is no intensive care. So in conclusion, pulse oximetry is an objective tool. It can be implemented at the lower health system levels to identify children with greater pneumonia mortality risk and potentially improve retention on the care pathway to reduce mortality if it's linked to treatment. So thanks for your attention. I'm sorry for the technical difficulties. I just want to call your attention to 2 Lancet commentaries that are coming out in today or the next day or 2. One will be in Lancet in Respiratory Medicine, and I've already highlighted the commentary in Lancet Infectious Diseases. I just want to acknowledge my collaborators, mentors, as well as sponsors for their support. Thank you.
Great. Thank you very much. You should consider a career in radio. Excellent voice. We have 10 minutes, and I want to make sure that if there are questions in the audience that they get asked. I certainly have a few more and could fill the time, but I just want to open it up. There are some microphones around. If you just raise your hand, we will get them to people. Question?
Thank you for that excellent session. I'm Anita Shed. I'm from IVAC. I have a question for Dr. Checkley. It was very exciting to hear about the ultrasound, and I've heard you talk before in Delhi. And I know as a pediatrician, I've worked in India, the challenges of getting an X-ray and having it read and so on. But one advantage of the X-ray is that at the bedside, you can just take it and read it as a physician, and you don't need a technical person typically. So I was just wondering, for ultrasound, do you have a set of guidelines that you can make with the existing evidence that can actually be distributed to physicians so that it can be easily interpreted and standardized, just like we have for the X-ray guidelines?
Yes, thank you for your question, and I think that's incredibly important in any type of imaging modality. So just like chest X-ray, I think we've had the opportunity to work on a standardized protocol to be able to detect pneumonia and identify consolidation, how large it is. And much of this work is being done in conjunction with Abdullah Baki and Eric McCollum in Bangladesh through one of the PCV surveillance studies that we currently have. So I think we think, and based on our experiences, is that this doesn't require a radiologist to read. And we also think you don't necessarily need to be a physician to be able to identify these, to identify a consolidation. You just need to have good pattern recognition. And it's coming to that question in terms of automated, for that same reason, I think an automated algorithm could also potentially identify areas where there's concern for a consolidation or suggesting a pneumonia that may require, that is consistent with a bacterial cause.
Also raised the question of telemedicine, right? You could have someone sitting across the street reading an awful lot of.
And that is true. We were actually recently with a group that has kind of a cloud-based system that showed us the it's an image that was collected, let's say I forget where it was. It's like it was kind of in a rural setting in Africa, and they were able to actually send a link to my iPhone to be able to open up the image and to be able to look at it right there in real time,
Yes.
in real time speaking. So that is an opportunity for telemedicine to be able to diagnose it also in real time.
Let me ask this one question to both of you. How do we think about oximetry and ultrasound together? Are there any studies that are, both versus one versus the other? They seem like a little bit like competitors, but obviously if you had a child, you'd want both. How do you think about that? And maybe Dr. McCollum, are you there? Do you want to?
Sure. I mean, can you hear me okay?
Yes.
Yeah, so I think, at least at this point, I would say one of the major differences between pulse oximetry and lung ultrasound is that pulse oximetry as a technology is probably further along in terms of being feasible for implementation, further downstream in the care pathway, as I kind of outlined. I mean, I think Will can talk to this more, but in my mind, I would envision right now lung ultrasound, if implemented, would be more wedded to a facility, probably a higher level hospital at this stage, whereas pulse oximetry has the ability to be used by actually a community health worker with basic skills.
Any thoughts?
And I agree with that. I think implementation, when you think about implementation, oximetry is something that is small. It can be rolled out at pretty much any level. A couple things though. I think there's a lot of potential for having kind of, they're both kind of adjuncts to the diagnosis of pneumonia. When you think about most of pneumonias are going to be diagnosed on symptoms and signs. So anything that has value added, like oximetry and imaging, and I think Eric made that point that the problem is that when you use an algorithm like the IMCI, you may actually miss cases just because you're trying to follow an algorithm. But so using some of these modalities, adjunct modalities for diagnosis, whether you do oximetry earlier on or even imaging earlier on, it could help identify those cases that are being missed.
Got it.
The other point, just to be able to add to that specifically, is that I think both of these technologies give you information kind of in a
Complementary way.
Yeah, it's complementary information. You're talking about imaging, and whether you're using X-ray, which is like an actual look at the anatomy, or ultrasound that looks at artifacts that is caused by disruptions in the anatomy. And whereas oximetry focuses more on on oxygen in the blood. So they give you additional information.
Fair enough.
Different information.
Great. I know that we've got someone with some experience on the device side. Why don't you introduce yourself?
Oh, okay. So my name is Christopher Koch. I ran my own company in biotechnology for a little while. But my question actually to you, sir, is this. Has there been any thought about implementing, I know a lot of our traditional low-cost ultrasound techniques, right? They give us a real-time image and they allow us to execute an overall scan of a patient. Has anyone looked at the idea of using some of our high storage modalities with a standardized actual form to teach our community health workers to execute an ultrasound, save it to a hard drive, and then potentially upload it to a cloud and compare that, say, a low-level read, say from a physician not trained in radiology versus a radiologist standardized read that comes maybe a few hours later, so that we can still deliver them urgent treatment, but then get a sort of definitive read later on, even if that read comes from, say, another country through telemedicine or one of these cloud technologies?
That's an excellent question. We're actually doing that right now in our study in Bangladesh. We are, where the physicians are making a diagnosis at the time that they read the ultrasound, and then the images are uploaded to a cloud-based server. And those are then read by our experts here at Hopkins. And the way we've worked out our algorithm is that we have two readers in Bangladesh that can do real-time assessment. And if there is any discrepancy between both readers, then it goes up, gets elevated. And we have kind of a time window when we're trying to get it in a somewhat real-time basis at the moment. Since it's a research protocol, we're giving it within 2 to 5 days to give an answer. But if we wanted to really roll it out as an implementation, and you can actually get this done much more quickly with newer technology that allows kind of more real-time communication between people in the field and experts in a workstation that are looking at that could be looking at images.
Great. Thank you. One last question here. Go ahead.
Hi, my name is Shakir. I'm a MSc student, and my question is to Dr. Chakli. And as far I know, these machines, the portable machines, they are very costly. So what do you think using them in third world country and in field level?
That's another great question. I think, for example, in the study that we use in Bangladesh, we're using pretty, I'd say, moderate to high-level price devices. Right now, I think the cost of one of the devices with a probe is around anywhere from $40,000 to $50,000, the one that we're currently using. So it is costly. However, I think it is, while it's costly, it's still cost-effective. So I think that's a point to take into account. I think prices of ultrasounds have also been decreasing dramatically. I think we're using a high-end device just because it's a proof of concept, but you can really get down to devices that are $8,000. I think a lot of it is still proprietary, so you can actually get to devices that are much cheaper. You can actually move to simpler technologies. In ultrasound, what you work is an array of ultrasound frequencies. You can actually simplify it by putting like simpler arrays and using those arrays. It could be much cheaper. You can actually get it done. Like a current portable ultrasound that is made by GE is now close to $8,000, and there are actually even cheaper implementations of it that really gets it down to the $2,000 to $3,000 devices.
Can I make one comment?
Yeah, actually, if you could make maybe the last comment, and if you could, from your perspective, in addition to whatever else you are going to say, I would like you to maybe, given your experience watching things start in research and translate over into saving so many lives, how do you think about these technologies?
Sure. Thank you, Josh, for that opportunity. In terms of cost, I think cost is obviously important, but we've learned from the vaccine experience, once you reach up to scale, if anything can be used globally, we can bring those costs down dramatically. When we started using hepatitis B in this country, it cost $100 a dose. People in the US said we could never afford this for the whole country. And now you know what hepatitis B vaccines cost. It's used all over the world. Rotavirus vaccine, which now in developed countries, we pay over $100 a dose, manufactured for $1 a dose in developing countries. I think once there's a proof of concept and then we can get commitment from the appropriate advisory bodies that these things should be used, then you can get developing country manufacturers interested. Once those developing country manufacturers get interested, the price goes down dramatically. So I think we need to do our homework on not just proving them at the scientific level, but we need to advocate for this at the political level and at the advocacy level with the international organizations. But Josh also asked me to summarize what we take away from all of this. As I said, we have made tremendous progress. There are new technologies that are coming up, and whenever something new comes up, you will get a lot of pushback, and as we're getting a lot of pushback with the ultrasound, how can we ever afford this? Also oximetry, how do you maintain these machines? It's fine, it sounds great, but do you have those enough probes? And how would you actually make sure that you train all these people and you get quality data? All those questions will have to be answered. But if we can take up the challenge, if there is political commitment to do these things, these are very promising new technologies. I do think both the ultrasound and pulse oximetry will greatly aid our diagnostic ability and will reduce mortality. But one of the other major gaps that we have is our ability to make etiological diagnosis. I think that is going to be the key. In the next 10 years, hopefully not even 10 years, if we can come up with a simple diagnostic technique that will tell us, yes, this is bacterial and it's treatable with antibiotics, that would be a huge step. Right now, we have a highly sensitive diagnostic technique, which you have to do. WHO says fast breathing, there are this algorithm, and then you use antibiotics on everybody. And that's creating huge problems because widespread use of antibiotics also causes antimicrobial resistance. So I think we are at a very exciting stage. I'm so glad all of you are here. I think we need to step up some of these new interventions. We as scientists are great at generating data, but we're terrible at communicating them. We're terrible at advocacy. I've learned a lot from our advocacy group and communication groups, and I really hope that we can then take these lessons and then scale them up around the world. There is no reason why a child should die from diarrhea at this day and age. There's no reason a child should die from a community-acquired pneumonia. I think we have the techniques. We just have to make sure we implement them. Thank you.
What a really interesting, terrific panel. Thank you so much, Dr. McCollum, Dr. Shekli, and all of you.